This course is a recording of an e-learning training. Audio narrations play throughout the course. You will not be able to navigate through the recording using the seatbar. However, you will be able to select closed captions if needed. All external links as well as resources provided as part of the training will be available in the YouTube description. Welcome to this course titled Health Practices and Medication Management. This course is developed as part of the Washington State Department of Children, Youth, and Families, DCYF's, efforts to prepare group care licensors for their roles and responsibilities as it pertains to interpreting, understanding, and applying the Washington Administrative Code, WAC, in licensing group care facilities, GCF. This course is designed to introduce you to the amended WAC requirements related to the health practices and medication management practices for GCFs. This course will focus on changes to the current WAC and specific amended language to pay particular attention to. Upon completion of this course, participants will have a shared understanding of the intent of the WAC covered in this module, know and understand the negotiated rulemaking, NRM, and strength-based principles associated with the WAC covered in this module, learn the scope of DCYF Licensing Division's, LD, role in group care facilities. Become familiar with the amended WAC that regulates group care facility requirements. Understand the health practices that GCFs must adhere to. Be aware of the medication management requirements for GCFs. As we cover the material in this course, please keep in mind the following guiding principles. We will revisit these at the end of the course to check in with you and give you an opportunity to assess your understanding and application of the course content. General principles. Group care licensees have a responsibility to ensure the health, safety, and well-being of children and youth in care. DCYF is responsible for protecting the children and youth in licensed group care programs. All licensed group care providers are required to operate facilities and provide services to children and youth in care in accordance with Revised Code of Washington, RCW, WAC, and DCYF policy and procedures.
NRM principles. Prioritizing youth safety and well-being above all else. Creating developmentally and culturally appropriate rules that meet the needs of children and youth placed in care. Minimizing barriers and reducing undue burden on the part of caregivers. Offering differentiation and flexibility between care settings to help support a variety of programs across the state, serving children and youth with diverse needs. Strength-based approach principles. Reducing bias. Checking biases helps reduce their influence on decision-making and builds fairness and equity in licensing practices. Recognizing strengths. Acknowledge and value licensees' expertise, consist in areas of compliance and capabilities to learn, grow, and change. Fostering understanding. Focus on a shared understanding of WAC intent and approach areas of noncompliance with curiosity to promote safe, thriving environments for children and youth. Achieving collaborative compliance. Honor cultural differences and perspectives to identify diverse methods of achieving compliance with WAC intent. Collaborative compliance principles. Shared decision-making. Collaborative compliance thrives on licensors and licensees working together to meet both WAC intent and child and youth safety and well-being needs. Encouraging innovation. Collaborative compliance relies on licensors empowering licensees to think creatively about customizing WAC compliance solutions to better meet the developmental and cultural needs of children and youth in care. Empowering licensees as experts. Collaborative compliance assumes that licensees are the experts of their facilities, homes, and programs. Embracing perspective and critical thinking. Collaborative compliance requires critical thinking from both licensors and licensees.
This course will cover the following sections from Chapter 110-145, WAC Health Practices and Medication Management, WAC 110-145-2930. Medical Consent and Care, WAC 110-145-2940, Evaluating Children's and Youth's Medical Needs at Admission, WAC 110-145-2950. Immunization requirements for children and youth. WAC 110-145-2960. Prevention of communicable disease. WAC 110-145-2970. Accepting, storing, and disposing of medication. WAC 110-145-2980. Medication administration and documentation. WAC 110-145-2990. Alcohol, marijuana, and illegal drugs. WAC 110-145-3000. Smoking and vaping. WAC 110-145-3100. Personal hygiene. WAC 110-145-3110. Food storage and preparation. WAC 110-145-3120. Meals, snacks, and menus. These revised standards enable DCYF to collaborate with providers in adopting developmentally and culturally appropriate and flexible practices that better support the unique needs of children and youth in care. Let us begin with WAC 110-145-2930, Medical Consent and Care. This WAC was formerly WAC 110-145-1845. What are the requirements for obtaining consent for emergency and routine medical care? The intent of this WAC is to ensure the well-being and autonomy of the children and youth in care, while respecting their rights and preferences. This WAC specifies who is authorized to provide consent for emergency and routine medical services and outlines the procedures licensees must follow when addressing the medical care needs of children and youth. It is important to note that this WAC does not include mental health treatment. Children and youth in group care facilities may require medication for various reasons. Some may need it to manage long-term health conditions, while others may take it temporarily for short-term illnesses. Regardless of the reason, managing medication is a significant responsibility entrusted to licensees to help ensure the health and well-being of the children and youth in their care. Additions to this WAC specify that licensees must obtain consent for medical care for a community child or youth from their parent, unless the child or youth has the legal authority to consent to their own medical care. The amended WAC also states that if a child or youth refuses medical treatment, the licensee must notify the child's or youth's representative. In life-threatening medical emergencies, licensees are required to call 911, even if the child or youth is refusing care. Throughout the NRM process, medical consultations were conducted with Fostering Wellbeing to examine the circumstances under which children and youth can access healthcare without parental or guardian consent. These consultations revealed that only specific types of medical care may be accessed independently, as there are limitations on what a parent or guardian can consent to on behalf of a minor. In Washington state, general age of majority for healthcare, meaning the age at which an individual can receive medical services without the permission of an authorized adult, is 18. You can read the state law about this at RCW 26.28.010. If you are under the age of 18, you may access healthcare services without an authorized adult's consent under certain conditions. These conditions include being married to an adult, RCW 26.28.020, being legally emancipated from your parents, RCW 13.64, being determined a mature minor by a healthcare provider, or in some cases, if you are homeless. Additionally, minors can independently access specific types of medical services under certain circumstances. These circumstances include emergency medical services, non-emergency medical services, immunization, including for COVID-19, sexually transmitted infection testing and treatment, including HIV, birth control services, abortion services, prenatal care services, gender care, outpatient mental health treatment, inpatient mental health treatment, outpatient substance abuse treatment, inpatient substance abuse treatment. As a dependent child or youth, the state serves as the legal guardian and holds the authority to provide medical consent. The form titled Caregiver Authorization is given to the provider by the social worker, which outlines the specific authority delegated by DCYF to the provider. WAC 110-145-2930 also states that licensees must consult with a child's or youth's established licensed healthcare provider when seeking medical advice, treatment, or exams, unless the specific listed requirements exist. Those specific listed requirements include: an emergency situation exists. The child's or youth's established licensed healthcare provider is not known to the licensee. The child's or youth's established licensed healthcare provider is not available within the necessary timeframe, or an in-person visit is required and the child's or youth's established licensed healthcare provider is not within reasonable proximity. The original WAC 110-145-1845 included that, in case of medical emergency, contact the child's DCYF caseworker and the child's tribal ICW case manager or intake as soon as possible. This requirement has since been moved to WAC 110-145-3060, which was reviewed in a previous module. WAC 110-145-2940, Evaluating Children's and Youth's Medical Needs at Admission, combines elements of the previous WAC 110-145-1835. Am I required to assess a child's need for immediate medical attention? And WAC 110-145-1840. When must I get an early and periodic screening, diagnosis, and treatment (EPSDT) exam for a child? The intent of the WAC is to ensure that children and youth receive the essential healthcare and services needed to support their health and well-being. It is important to pay attention to the definition of an early periodic screening, diagnosis, and treatment (EPSDT) exam. Early periodic screening, diagnosis, and treatment (EPSDT) means an early periodic screening, diagnosis, and treatment exam completed by a licensed healthcare provider. Licensees are responsible for assessing the current health status of children and youth by gathering all relevant information about their immediate medical needs upon admission. Except for interim facilities, licensees must also ensure that children and youth receive either an initial health screening by a licensed healthcare provider or an EPSDT examination. The following sections will highlight important updates and additions to these requirements. Additions to this WAC specify the required components of an EPSDT exam for all licensees, except for interim facilities. In accordance with WAC 110-145-2940 subsection 7, EPSDTs, licensees must, except for interim facilities, take children and youth to a licensed healthcare provider for an EPSDT exam within the first 30 days of entering a licensee's care, unless they have had an EPSDT exam in the last 30 days. Obtain a copy of documentation of the EPSDT exam. Verify the EPSDT documentation is signed by the licensed healthcare provider and identifies any chronic medical issues, immediate health concerns, and follow-up actions or appointments needed. Notify the child's or youth representatives of the date of the scheduled exam if an appointment with a licensed healthcare provider is not available within the required timeframes in the section, and follow the schedule outlined by a licensed healthcare provider for subsequent periodic EPSDT exams. Another important addition to this WAC is the requirement to notify the child's or youth's representative of the scheduled exam date if an appointment is not available within the required timelines. Additionally, the new WAC extends the deadline for the initial health screening from within 5 days to within 14 days, unless specific exceptions apply. This WAC also includes updated language, changing except for overnight youth shelters to except for interim facilities. In accordance with WAC 110-145-2940 subsection 5, licensees must take children or youth to a licensed healthcare provider for an initial health screen, except for interim facilities when the children or youth enter out-of-home care for the first time or it is their first placement other than having been in interim facilities, and as soon as possible but no later than 14 days after entering the licensee's care, or unless the child or youth came to the facility from a hospital or pediatric interim care, is receiving services through a child or youth advocacy center or sexual assault clinic, has had an early periodic screening, diagnosis, and treatment (EPSDT) exam in the last 30 days, receives an EPSDT exam within the first 14 days of entering the licensee's care, Or, the child or youth entered DDA services as a community child or youth with a voluntary placement agreement. Now we will focus on WAC 110-145-2950, Immunization Requirements for Children and Youth, which is a combination of WAC 110-145-1520 and 110-145-1885 from the previous group care chapter. The intent of this WAC is to provide guidance on the immunization requirements for children and youth in licensed group care. The WAC allows for 3 potential exemptions: medical, religious, and philosophical or personal. Exemptions must be supported by consent from a parent or guardian and approval from the appropriate required professional. This WAC also requires a licensee to ensure that any child or youth who is not up to date on immunizations and does not have exemptions on file is taken to a licensed healthcare provider to catch up on their immunization schedule. Ensuring that as many children and youth in a licensed facility are up to date on their immunizations helps protect both the residents and facility personnel from serious illness and related health risks. This WAC has updated language regarding the exemptions to immunization requirements. Facility personnel are no longer required to notify a child's or youth's caseworker or licensor when a serious infection or communicable disease poses a threat to children or youth in a licensed group care facility. It is also important to focus on the prevention of communicable diseases within licensed group care settings. WAC 110-145-2960, titled Prevention of Communicable Disease, provides guidance to licensees on preventing the spread of communicable disease within their facilities, ensuring the safety and protection of the children and youth in care and facility personnel. In the previous WAC chapter, this was WAC 110-145-1635. This amended WAC includes several minor language updates to include revised definitions. The first edition permits the department to recommend that licensees caring for fewer than 13 children and youth consult with a registered nurse, RN, or licensed healthcare provider to assist in developing and reviewing their infection control policies and procedures. Additionally, facilities that care for medically fragile children and youth are now required to have an infection control program supervised by an RN or certified infection preventionist. It is important to pay attention to the definition of a licensed healthcare provider. Licensed healthcare providers means medical doctors, doctors of osteopathy, doctors of naturopathy, physician's assistants, or advanced registered nurse practitioners. Registered nurses, RNs, means nurse as defined in RCW 18.79.020. Proper procedures for accepting, storing, and disposing of medication are essential to ensure the safety and well-being of children and youth in care. WAC 110-145-2970, Accepting, Storing, and Disposing of Medication, combines elements of previous WAC 110-145-1850, 110-145-1870, and 110-145-1875. The intent of this WAC is to ensure that licensees establish a comprehensive medication management policy and procedure approved by the department that addresses medication storage, proper documentation, safe handling, and disposal of medications. This new WAC introduces language requiring licensees to develop and follow department-approved policies and procedures for accepting, storing, and disposing of medication. Facilities that care for 13 or more children and youth must arrange for a registered nurse, RN, or a licensed healthcare provider to assist in developing and periodically reviewing these policies and procedures. For facilities serving fewer than 13 children and youth, the department may recommend consultation with an RN or licensed healthcare provider for the same purpose. When licensees are accepting medication for children and youth in care, this WAC requires that medications for children and youth must be kept in pharmacy-labeled containers. This WAC updated the language must notify caseworker when there are concerns about medications provided by child's parent, guardian, or relative to must consult and follow recommendations of the medication prescriber, a pharmacist, or a licensed healthcare provider. Regarding the storage of medication, this WAC provides requirements for storing medication and storing emergency medication. When licensees are developing their plan for storing medication, They must also include storing medication as directed by the manufacturer's specifications. Furthermore, licensees must have a written plan for children and youth who have emergency medications that are reflective of their developmental capabilities. In accordance with WAC 110-145-2970, licensees must have a written plan for children and youth in care who have emergency medication other than naloxone nasal spray that is reflective of their developmental capabilities. This plan must outline the following: how the medication will be easily accessible in an emergency, how the medication will be kept inaccessible to other children and youth in care, and the plan for taking medication off-site. However, when naloxone is on-site and in a nasal spray form, it must be stored in a place where it is easily accessible in case of an emergency, and if children or youth come into care with naloxone nasal spray, they may keep it with their personal belongings. Finally, it is important to note that naloxone in an injectable form must be stored in a locked container. For disposing medication, a substantive change to this WAC is that licensees no longer must consult with a pharmacist or other health professional on the proper disposal of medications that are no longer being taken or have expired. Now, licensees must follow the Food and Drug Administration guidelines for proper disposal of medications that are no longer being taken or have expired. Lastly, through the NRM process, WAC 110-145-2970 retained all previous requirements for how licensees must dispose of medications and added a new requirement that licensees must now document the date on which the medication was disposed. In addition to proper acceptance, storage, and disposal, the safe administration of medication and accurate documentation are critical components of effective medication management in licensed facilities. WAC 110-145-2980, Medication Administration and Documentation, combines elements of previous WAC 110-145-1855, 110-145-1860, 110-145-1865, and 110-145-1880. The intent of this WAC is to ensure that children and youth receive the correct medication in the correct dosage at the correct time. It also provides guidance to help licensees understand medication management requirements in which personnel are authorized to access medications and the specific responsibilities involved in caring for medically fragile children and youth. For medications to be effective and safe, they must be administered to the right person at the right time and in the right dose. This applies to both prescription and non-prescription medications. Over-the-counter medications, which are available without a prescription, can be just as dangerous as prescription medications if misused. Administering the wrong medication, an incorrect dose, or giving it at the wrong time can lead to serious, even life-threatening, consequences. This new WAC includes a requirement that at least one direct care personnel or direct care volunteer who has completed department-approved medication training must be on duty whenever children and youth are present. This individual must be able to dispense medication and complete the required documentation. Training personnel is a critical component of operating a safe and effective group care facility. The WAC also specifies who is permitted to access children's and youth's medications, and this includes licensees, authorized individuals providing care, including respite care providers, and children and youth when taking their own medication. Additional requirements in this WAC state that licensees may only reduce or stop a child's or youth's prescribed medication without written approval from a licensed healthcare provider under two specific conditions, and only if the listed procedures are followed. According to WAC 110-145-2980, this may occur when a child or youth has an adverse reaction, such as an allergic reaction to the medication. But licensees must follow up with a licensed healthcare provider within 48 hours for an updated medication order, or the licensee must obtain instructions from a licensed healthcare provider over the phone to reduce or stop giving the medication to the child or youth. In addition to these requirements, the licensee must also document and follow the order and obtain a copy of the order from the licensed healthcare provider within 72 hours. Licensees are required to document not only medications that are administered, but also those that are missed or refused. If a child or youth misses or refuses medication for 2 consecutive days, The licensee must consult with a licensed healthcare provider. In such cases, licensees must also comply with WAC 110-145-3060 additional requirements when caring for Indian children, which addresses the use of Native American traditional medicines. WAC 110-145-3060 will be reviewed in a later module. Additionally, WAC 110-145-2980 introduces a requirement regarding dietary supplements. Licensees may approve the use of dietary supplements for use by department or tribal children and youth, while parents or guardians may provide approval for community children and youth. If licensees require a medical consultation before approving supplement use, they must notify child's or youth's representative. Following a medical consultation with a DCYF contracted MD, as part of the NRM process, it was confirmed that the requirement in previous WAC 110-145-1855 subsection 8, you must obtain a signature from a licensed healthcare provider within 72 hours of obtaining a medication order by phone, would be included for safety reasons. A verbal medication order, such as one given over the phone, carries the risk of being misinterpreted by the person receiving it. The contracted MD explained that in medical practice, when a nurse receives a verbal order, the prescribing provider is required to sign that order within 24 hours to minimize the risk of error, whether due to the medical professional misspeaking or the recipient mishearing. The contracted MD emphasized that this section of the WAC was written as a safety measure specifically to catch and correct such potential mistakes. In accordance with WAC 110-145-2980, licensees who care for medically fragile children and youth must have an RN or LPN receive a medication order over the phone from a licensed healthcare provider and obtain a signed copy of the order. For many children and youth, taking medication is a regular part of daily life, particularly for those managing chronic conditions such as diabetes or asthma. In such cases, children and youth may have learned to administer their medication independently at a young age. Developing the ability to take medication independently is often an important step in building self-sufficiency and practicing self-care. In accordance with WAC 110-145-2980, licensees may permit children or youth to take their own medication and herbal supplements when the child or youth has the developmental capability to properly take them. Should this be the case, licensees must obtain and keep on record written approval by the child's or youth's representatives, except OYSs and CRCs. For youth 18 years old or older who consent to their own medical care, licensees are required to monitor that the child or youth is taking the medication or herbal supplement according to the prescription or manufacturer's instructions, including the proper amount and frequency, and store the medication or herbal supplement and medical supplies in a way that is inaccessible to individuals who are not authorized to access the medication. Next, we will turn our focus to WAC 110-145-2990, alcohol, marijuana, and illegal drugs, formerly WAC 110-145-1650. The intent of this WAC is to outline the requirements surrounding the possession, use, and influence of alcohol, marijuana, and illegal drugs in a licensed facility. This WAC prohibits the possession, use, or presence of personnel under the influence of alcohol, marijuana, or illegal drugs on the premises or being in contact with children or youth in care. While there were no substantive changes to the amended WAC, the language was revised for clarity, replacing the phrase must not with must prohibit. In addition to restrictions on alcohol, marijuana, and illegal drugs reviewed in WAC 110-145-2990, there are specific regulations outlined in WAC 110-145-3000, smoking and vaping, to further protect the health and safety of children and youth in care. The intent of this WAC, formerly WAC 110-145-1655, is to define the regulations and requirements regarding smoking and vaping within licensed facilities and while transporting children or youth in motor vehicles. As a result of the NRM process, this WAC now includes language specifying the minimum age requirements for adults permitted to smoke or vape outdoors on the premises, away from children. Additionally, the updated WAC incorporates the term vaping, which refers to the alternative method of the inhalation of tobacco-based products through electronic devices. Furthermore, the addition of the term vaping was included in the WAC to clarify that the regulations apply to all forms of tobacco inhalation. The previous WAC 110-145-1655 permitted adults to smoke outdoors away from children but did not specify an age requirement. The WAC was amended to comply with Washington State House Bill HB 1074, which raised the legal age requirement to purchase or distribute tobacco and vaping products to 21 years or older. Before HB 1074, adults were defined as anyone 18 years or older and could legally purchase or distribute tobacco products. The amended WAC clarifies this by specifying the age requirement for individuals permitted to smoke or vape outdoors on facility premises, away from children and youth, in accordance with RCW 70.160.075. Maintaining proper personal hygiene is essential to promoting the health, dignity, and well-being of children and youth in care. WAC 110-145-3100, Personal Hygiene, formerly WAC 110-145-1780, outlines the standards and responsibilities for licensees to ensure that children and youth have access to the hygiene supplies, facilities, and support needed to meet their personal hygiene needs. This WAC was updated to promote more inclusive and safer care practices for children and youth in GCFs. The revised rule now includes a requirement for providing culturally appropriate items, recognizing the importance of respecting and supporting the diverse backgrounds and personal dignity of children and youth. Additionally, the update emphasizes safety by requiring that toxic hygiene products be kept inaccessible, in alignment with WAC 110-145-2450. These changes help ensure that personal hygiene routines are both respectful and secure, supporting the overall well-being and safety of those in care. Safe and sanitary food storage and preparation are critical components of maintaining the health and well-being of children and youth in care, which is outlined in WAC 110-145-3110 Food Storage and Preparation. The intent of WAC 110-145-3110 is to provide licensees with clear guidelines for the handling, preparation, and storage of food, ensuring meals served to children and youth in care are safe and comply with State Board of Health standards. In addition, permitting children and youth to assist with food preparation and service offers opportunities for meaningful, developmentally appropriate engagement. This aligns with the NRM guiding principles, which emphasize the importance of child safety, well-being, and active participation in daily life activities. WAC 110-145-3110 Food Storage and Preparation combines elements of previous WAC 110-145-1555 subsection 3 and 110-145-1790 subsection 4, outlining the licensee's responsibilities for food preparation, storage, and maintaining sanitary conditions in accordance with State Board of Health regulations. The updated WAC introduces new language allowing children and youth to assist in preparing and serving food to others within the facility, provided food worker card requirements are met. The WAC stipulates that children or youth may prepare and serve food regularly under the supervision of personnel with a valid food worker card, or occasionally if they have received safe food handling training from such personnel. Additionally, the updated WAC removes previous guidelines from the previous WAC 110-145-1790 on meal planning and menus, meal schedules, and dietary accommodations for children or youth. These topics are now addressed separately in WAC 110-145-3120, which focuses on the requirements surrounding the provision of meals, snacks, and menus. Building on the foundation of food safety and preparation, the next WAC we will review, WAC 110-145-3120 Meals, Snacks, and Menus, focuses on the nutritional aspect of care by outlining the requirements for providing meals, snacks, and menus that meet the dietary needs of children and youth in licensed facilities. The intent of WAC 110-145-3120 is to outline clear requirements for licensees regarding the provision of meals, snacks, and menus that support the nutritional, cultural, and developmental needs of children or youth in care. The amended WAC consolidates WAC 110-145-1790, 110-145-1795, 110-145-1800, and 110-145-2075 into a single set of guidelines outlining meal and menu requirements for licensees providing food to children and youth in care. A notable addition is the requirement for licensees caring for medically fragile children and youth to incorporate culturally enjoyable foods into meals, as approved by the child or youth's licensed healthcare provider. Regarding special or modified diets, the updated WAC continues to require licensees to follow dietary plans prescribed by the child or youth's licensed healthcare provider. However, it removes the previous requirement for approval of the child or youth's DCYF caseworker. This change reflects the reality that not all children and youth served in licensed GCFs are under DCYF custody and therefore may not have an assigned caseworker. There are no substantive changes from the previous WAC concerning the required number of meals and snacks served daily, the provision of daily menus, mealtime schedules, or the retention of menu records. Similarly, the requirements for personnel awareness of children's or youth's dietary restrictions remain unchanged. Previously, WAC 110-145-1790 prohibited serving home-canned foods to children and youth. The revised WAC now permits home-canned foods to be served in licensed facilities under specific conditions, including prior DCYF approval and adherence to USDA food preparation and canning guidelines. Additionally, the updated WAC allows children and youth to participate in growing and canning the food served. This amendment supports developmentally appropriate activities that promote well-being, aligning with the NRM guiding principles that prioritize child safety and overall well-being. Before we continue, let's test your learning. Review the question and select the best response. Licensees must take children or youth to a licensed healthcare provider for an initial health screen, except for interim facilities. WAC 110-145-2940 subsection 5. A. When the children or youth enter out-of-home care for the first time, or it is their first placement other than having been in interim facilities, and WAC 110-145-2940 subsection 5. B. As soon as possible but no later than A. 5 days after entering the licensee's care. B. 10 days after entering the licensee's care. C. 14 days after entering the licensee's care. That's correct. In accordance with WAC 110-145-2940, licensees must take children or youth to a licensed healthcare provider for an initial health screen, except for interim facilities. Subsection 5. A. When the children or youth enter out-of-home care for the first time, or it is their first placement other than having been in interim facilities. And subsection 5. B. As soon as possible but no later than 14 days after entering the licensee's care. Before we continue, let's test your learning. Review the question and select true or false. Facilities that care for 13 or more children and youth must arrange for a registered nurse, RN, or a licensed healthcare provider to assist in developing and periodically reviewing a licensee's policy and procedure for accepting, storing, and disposing of medication. True. False. That's correct. In accordance with the amended WAC 110-145-2910, accepting, storing, and disposing of medication, licensees are required to establish a comprehensive medication management policy and procedure approved by the department that addresses medication storage, proper documentation, safe handling, and disposal of medication. The amended WAC requires that facilities that care for 13 or more children and youth must arrange for a registered nurse, RN, or a licensed healthcare provider to assist in developing and periodically reviewing the licensee's comprehensive medication management policy and procedure. This concludes the content portion of this course. Thank you for your participation. Before this course ends, please take a moment to reflect and set personal goals related to the following guiding principles and ways that each of the principles relate to group care facilities. General principles. Group care licensees have a responsibility to ensure the health, safety, and well-being of children and youth in care. DCYF is responsible for protecting the children and youth in licensed group care programs. All licensed group care providers are required to operate facilities and provide services to children and youth in care in accordance with Revised Code of Washington, RCW, WAC, and DCYF policy and procedures.
NRM principles. Prioritizing youth safety and well-being above all else. Creating developmentally and culturally appropriate rules that meet the needs of children and youth placed in care. Minimizing barriers and reducing undue burden on the part of caregivers. Offering differentiation and flexibility between care settings to help support a variety of programs across the state, serving children and youth with diverse needs. Strength-based approach principles. Reducing bias. Checking biases helps reduce their influence on decision-making and builds fairness and equity in licensing practices. Recognizing strengths. Acknowledge and value licensees' expertise, consist in areas of compliance and capabilities to learn, grow, and change. Fostering understanding. Focus on a shared understanding of WAC intent and approach areas of noncompliance with curiosity to promote safe, thriving environments for children and youth. Achieving collaborative compliance. Honor cultural differences and perspectives to identify diverse methods of achieving compliance with WAC intent. Collaborative compliance principles. Shared decision-making. Collaborative compliance thrives on licensors and licensees working together to meet both WAC intent and child and youth safety and well-being needs. Encouraging innovation. Collaborative compliance relies on licensors empowering licensees to think creatively about customizing WAC compliance solutions to better meet the developmental and cultural needs of children and youth in care. Empowering licensees as experts. Collaborative compliance assumes that licensees are the experts of their facilities, homes, and programs. Embracing perspective and critical thinking. Collaborative compliance requires critical thinking from both licensors and licensees.
This concludes this course on health practices and medication management. If you have questions following this session, please contact your supervisor. We hope this course has been helpful in providing information about the licensing role and job expectations. Our goal is that all ND professionals viewing this course have left with an increased understanding and knowledge of health practices and medication management, as well as a general understanding of areas where strength-based approach principles should be emphasized.